Good morning, good afternoon. Welcome to the webinar. This is the Averting a Dual Disaster in Africa, Protecting Essential Health Services during COVID-19. I'd like to welcome you myself. My name is Jean Goodman. I will be your IT support for the webinar. You are welcome to contact me if you're having any kinds of problems. Next slide, please. During this webinar, if you are having any kind of audio problems or would like to change your audio connection, you can choose the audio options in the Communicate menu under Audio Connection and choose either I will call in or you can choose call using computer. And next slide, please. And during the webinar, we will be taking questions. If you will click the chat icon, it should be appearing at the bottom of your screen. It looks like a chat bubble. You can contact us and submit your questions. With that, I would like to leave you in the more than capable hands of your moderator, Midori Dahabich.
That is with us on today's webinar on averting a dual disaster in Africa, protecting essential health services in Africa during the COVID-19 pandemic. I am Midori Dahabich, and I will be moderating the discussion with four expert panelists that you can see on the screen. As we have already learned by now, the COVID-19 pandemic has had substantial health, social, and economic impacts in all countries, rich and poor, and continue to do so. Countries have to mount an emergency response to this terrible new disease, and at the same time have to continue providing critical and essential services for people in all countries. In middle and lower and middle income countries, certainly with very limited resources. To discuss these challenges, we have today four distinguished panelists that bring very valuable perspectives to the table. We will begin with two presentations about the case of COVID-19 and responses to it in Africa, followed by a panel discussion to delve deeper into the approaches being used to ensure continued access to essential care for people with other non-COVID health needs. As Jean was saying, throughout this webinar, we would like to encourage you to submit questions and comments going to the chat box on your screen. We would very much want your participation in this discussion. Now I would like to welcome our first presenter, Dr. Ambrose Tasiluna. Dr. Tasiluna is a health security expert with the World Health Organization's Regional Office for Africa. He currently serves as the WHO Africa Region Program Manager for Emergency Preparedness and Co-Incident Manager for COVID-19. So he brings a wealth of experience. Over to you, Dr. Tasiluna.
Thank you very much, Midori. In the next couple of minutes, I'll be talking through the regional overview of the COVID-19 and introducing the concept of health system resilience. Next slide, please. As you can see, I submitted these slides last week, and it's really COVID-19 is a moving target. As of today, we have 948 cases, and unfortunately, 2,675 of them have died. In that graph, we can see that the continent is not experiencing COVID-19 at the same rate. We see large numbers of infection in the West African part of the continent and also in southern part of the continent, a bit in the North Africa. In East and Central, they are slightly less. So, about 10 of the countries in Africa actually are contributing to the burden of the outbreak, and these are really Nigeria, Ghana, Cameroon, Senegal, DRC, Guinea, Cote d'Ivoire, Gabon, Algeria, and South Africa. Next slide. In early February, we did, when the COVID-19 was declared a public health emergency of international concern, we did a readiness assessment to look at how ready countries were with respect to responding to COVID. And we looked at 9 critical pillars: logistics, coordination, risk communication and community engagement, laboratory capacity, points of entry, surveillance, infection prevention and control, rapid response teams, and case management. And we found that overall readiness was about 66%. Major gaps were reported in the areas of rapid response teams, infection prevention and control, case management, and risk communication and community engagement. Next slide. When we looked at the countries, we found at that time in February, 8 of the countries reported that they were that adequate readiness, and 33 of the countries said they were having limited readiness, and 6 of them were like really not ready. We have done the repeat of this in March, and the number of countries that reported they were ready had improved from 8 to 10, and those ones that were saying they were not ready had dropped from 6 to 3. Next slide. Let me now introduce the notion of health system readiness. What is health system readiness? And I think in 2015, Margaret Clark and colleagues really published a critical paper in the Lancet when we had the Ebola outbreak in West Africa. And they defined health system readiness as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crisis, maintain core functions when the crisis hits, and be informed by those lessons. So it's really the ability to maintain essential services even in the presence of a shock event. And there can be multiple shock events that can disrupt essential services. They could be acute based on duration, or they could be chronic, or some of them, when they become chronic, we say that they are protracted. They could be disease events. We saw this in the Ebola outbreak in West Africa. We are seeing this in COVID. They could be environmental events. We saw this in floods in Sierra Leone. They could be drought. It could be economic events as well, sudden economic downturn with a sudden reduction in health funding. It could also be a slow economic deterioration like we've seen in some countries with instability and political disruption. But it could also be political events. So I think these are very common. And as a continent, we need really to be able to deal with these shock events and at the same time maintain essential services. Next slide. Again, in the paper by Margaret Clark, we have adapted a resilience framework, and we call them at the WHO regional level, we're calling them the vital signs of resilience. And one of them is really the awareness capacity. Awareness capacity is looking at ability of the system to have information, to know where people are, surveillance systems, what are the resources available. So that's really the knowledge. It helps us to be aware. The second critical vital sign really for resilience is diversity capacity. And this is really the ability to provide and respond to a wide range of services. And the primary healthcare model really is the best explanation for this, and universal health coverage. And really, we need to be providing a whole set of essential services. And then versatility capacity. This is really the ability to move resources, and it's also sometimes as we call self-regulation, the ability to contain health threats while at the same time maintaining basic services, the ability to mobilize and track resources during health emergency, the ability to provide incentives to health workers involved. So that is another critical sign. And then the other is mobilization capacity. Sometimes it's also been called integration, because this is really the local mandate to mobilize resources, bring on multiple stakeholders, different actors in an integrated system. And finally, the transformation capacity, which is really also sometimes termed as active, so that what do we learn from these shocks? In the emergency program, we do after action reviews, but have we learned over the last outbreaks what went well, what didn't go well? Then we make amendments, because we saw this in the West Africa outbreak of Ebola, and essential services were really disrupted. People died of malaria, children were not immunized, there was increase in maternal mortality. These are some of the things we should avoid when we have outbreaks. Next slide, please. Now, we've looked I'm going to introduce those two concepts. From preparedness, where we call it the International Health Regulations Capacity Index, and then the Resilience System Index that I've been talking about in the last slide. For the International Health Regulations is the global framework to help us protect against all hazards, to respond to all hazards, infectious, non-infectious, food safety, zoonotic, across the board, all hazards. And this has been signed on to by all member states, all the member states. Now, to assess the international availability of international health regulation capacities, we use two approaches. One approach is called the Joint External Evaluation, and the other is called the State Party Annual Report. And I'm only going to be presenting for this index the data from the State Party Annual Report because this is mandatory. And over the last 3 years, every member state in the WHO African region has reported. So the capacities are in 13 critical areas: legislation and financing, IHR coordination mechanisms, zoonotic events, food safety, laboratory, surveillance, human resources, response capacity, service provision, risk communication, points of entry, very, very critical because you've had border closures, and then chemical and radiation emergencies. So we've looked at 24 indicators and come up with the IHR capacity index. And then when you look at the vital signs, we have also come up with a health system resilience index. So we've aggregated this and come up with the final map showing you regional resilience index. And you can see that there are really disparities in the continent with respect to resilience. Next slide. So to sum up, really, what we are seeing is that there are varying country capacities to mitigate effects of shock events. We need a strong resilience index, which covers both the international health regulation, which is the global framework, and the health system resilience index. Now, we have 4 broad country classifications. One are those countries that have both a very strong health system resilience and IHR capacity. For those, we really need to do close monitoring of essential service continuity in this COVID outbreak, but they might also need targeted support on request. The second category of countries are those with strong system resilience, but they have a weak IHR capacity. For these, we need to accelerate IHR capacity building. We need to strengthen integrated disease surveillance and response. We need to develop contingency plans to be able to respond to this COVID outbreak, but also national action plans for health security that are cut across sectors for them to be able to build those gaps. The third group are those with a weak health system, but a strong IHR capacity index. For those countries, we need to accelerate the resilience capacity, try to build capacity to deliver an essential package of services, even in this COVID, but also maintaining capacity for us to be able to respond in case we have an outbreak. And finally, we have a group that has both low health system resilience and IHR capacity index. Now, that is an urgent group. We need to urgently, for those countries, really focus on emergency measures for both system resilience and IHR core capacity. So in a nutshell, in the little time that I had, I think this is really what we should do. But COVID-19, just like Ebola in 2014, 2016, if we don't maintain continuity of essential services, we'll have mortality increase due to COVID cases. I thank you very much. And as they say in East Africa, Asante Sana.
Thank you so much, Ambrose, for your very interesting presentation. Yes, in fact, this pandemic has reignited the debate that began during previous health emergencies, how to make them sufficiently resilient to manage shocks in ways that protect everybody, especially the most vulnerable. Have we really learned from previous emergencies? What can Africa learn from the ongoing pandemic in other continents? There's lots to see there, maybe learning from mistakes as well. So thank you so much for bringing this debate to life again, Dr. Ambrose. Now I would like to present Dr. Richard Lascelles. He's an infectious disease specialist at the University of KwaZulu-Natal in Durban, South Africa, who will take us inside the province's COVID-19 Emergency Operations Center, also known as the War Room. Welcome. Thank you so much for being with us. Dr. Lascelles, over to you.
Thank you very much, Midori, and good afternoon, good attendees. So as said, I'm an infectious diseases doctor and clinical epidemiologist based in Durban, South Africa. And just in these few minutes, I just want to give you a sense of what's happening in South Africa. As you saw from Ambrose's slide, South Africa's responsible for about a third of all cases in the WHO African region. And then also share with you some of the data that's starting to come out about the impact of COVID-19 and our response to it on maintaining essential health services. I think that many of us will have seen some of the modeling that alarms us about the potential impact. But as with much in this epidemic, we want to now start understanding the reality and seeing some real data to see what we're faced with at the moment and how we respond to that. So next slide, please. So this is just to give you a sense of the epidemic trajectory in South Africa. So this is a graph you'll all be familiar with of just the total confirmed cases over time. And we're now just entering the 4th month of the COVID epidemic in South Africa. And many of you will be aware that South Africa, like many African countries, made a very early decisive response to the epidemic. Within a couple of weeks of the first case, declared a national state of disaster, which came with various travel restrictions, school closures, and other initial measures. And then just a week or two after that, we went to a hard lockdown and what we now class as level 5. Unfortunately, we didn't control the epidemic completely. And what we've seen since then is that we've started to gradually ease the level of lockdown. And actually this week, we've just moved to level 3 lockdown. But the epidemic is now accelerating again. So we have this uncertain period where we're moving out of lockdown, but seeing many more cases, and that gives the potential, obviously, that we're going to have a prolonged period of disruption to normal health services. Next slide, please. What we see, though, is that the epidemic in South Africa is very heterogeneous, and I'm sure this is similar across other African countries too. Here is just the breakdown by province and showing the cumulative number of confirmed cases again. And you can see that this acceleration has been driven largely by the epidemic in the Western Cape province, which during the lockdown has seen a number of clustered cases in healthcare facilities, in workplaces, large factories, and that has then spilled over into the general community. In terms of my own province, KZN, KwaZulu-Natal, you can see in red, we have a much more gradual rise in the number of cases. So just giving you a sense of the disparity across provinces. Next slide, please. If we look at a district level, you can see this even more starkly. That there are many districts in South Africa which really haven't been affected hardly at all by the epidemic yet, particularly the more rural districts, the less well-developed and lower population density districts. So like we've seen in many countries around the world, the epidemic is centered on the larger urban centers in the country. And while we have said that we're moving to a district level system where the level of lockdown may vary by district according to the burden of disease, that in reality has not yet happened, and all the measures are still delivered on a national level. So that means as health systems are still preparing themselves and have maybe disrupted other health services. Many services are sitting waiting, unsure whether there's a wave of COVID coming to hit them or whether that's going to be averted. Next slide, please. So, as I said, just to give you a sense of some of the data that's starting to come out that gives us some sense of how the epidemic and how the lockdown may be starting to affect some of the other essential health services. This is the first indicator from a nationwide survey run by the Human Sciences Research Council in South Africa, which was open for anyone to participate in, and around 20,000 people participated. And one of the key questions in this survey was whether people had any difficulty accessing their chronic medication. So chronic medication could be HIV or diabetes, hypertension, heart disease medication. And overall, 13% of respondents reported that their chronic medication was not easily accessible. As you can see from the graph, there was a little bit of difference according to type of residence. So people in rural areas and in informal settlements had slightly higher response, saying that their medication was not easily accessible. Next slide, please. Something that worried a lot of us that have an interest in TB and how COVID and how the lockdown could impact on TB and TB transmission in the population. Some worrying data from the National Health Laboratory Service in South Africa, just tracking the number of sputum tests performed by their network of laboratories. We do a huge amount of TB tests in South Africa, about 2 million a year, which translates around 40,000 a week or so. And you can see here the two red lines here are when the initial national state of disaster is announced, and then the second red line is basically when the hard lockdown was instituted. And what you can see is from that first national state of disaster announcement, there was a significant drop-off in the number of TB tests being performed, and that then persisted after the hard lockdown. So overall, almost a 50% decline in the number of weekly tests done for TB. And this was mirrored in the decline in the number of positive tests that came through the lab. So clearly a concern, especially when people are spending more time indoors amongst their household, that if there's delays in TB diagnosis, then we may see more TB transmission. Next slide, please. Just a counterpoint to this is some data that's just recently released in a preprint article from some colleagues of mine in KwaZulu-Natal working at the Africa Health Research Institute. And they run a big health and demographic surveillance system in rural KwaZulu-Natal, which covers about 11 primary healthcare clinics. And because of their system that's set up, they are able to monitor clinic visits both prior to the lockdown and then after the lockdown. And so they analyzed whether there was any significant change in the number of visits and the number of people visiting the clinics for various reasons in the period before the lockdown and after the lockdown. And this graph just shows that here the red line is the time of the lockdown. And so you see the number of visits before and then after the lockdown. And overall, they saw no change in the total number of clinic visits per clinic per day from before to after the lockdown. Next slide, please. But when they broke this down to different purposes, you see some differences here. So if you look at the top, there's a few different reasons for visiting the clinic. And what you can see is a sign that there was a significant reduction in child health visits after the lockdown. And I think that's something that's been reported from other centers, a concern that child vaccination visits and things may be being missed. Conversely, they actually saw an increase in HIV visits immediately after the lockdown. And that makes sense to us, as we know that many people would be eager to get a supply of their HIV medicine to tide them over during the lockdown. And there's certainly been a big move in South Africa to try and give longer durations of refills of antiretroviral medicines, so that to limit the number of healthcare visits needed by people. So just to point out that this, of course, is one site. It's in an area that if you remember my figure before, this is a district that hasn't really been hit yet by COVID. And so that may affect these findings, that may find that people's risk perception is different here. People may not perceive themselves to be at risk of COVID and may be happy to continue visiting and receiving their essential health services. Next slide, please. I just finish by what has become my concern and my passion over the past month or two is really about what we do to avert healthcare worker infections, because it's clear to me we can't maintain essential health services if we don't have essential health workers. And we saw firsthand here in Durban, KwaZulu-Natal, the potential for this virus to cause a lot of disruption in that sense. We investigated a single outbreak in actually a private hospital here in Durban, where a single introduction of the virus to the hospital led to around 135 infections, and that includes 88 staff. And I think what we're seeing in Western Cape now, the health system has become overwhelmed by the numbers of cases that we're starting to see large numbers of health workers infected, and unfortunately starting to see healthcare worker deaths. And so coming back to Ambrose's presentation, where he highlighted the importance of infection prevention and control, it's clear to me that that's something we need to really strengthen if we're to protect our frontline healthcare workers and maintain those essential services in the short and the long term. Next slide, please. Which I think is the end. So I finish there, and I look forward to discussion of some of the data that I've presented, and how that relates to other settings and other experiences. Thank you very much.
Thank you so much, Richard. In fact, your presentation points to a very important issue, which is the availability of data to understand and monitor both the COVID epidemic and also, alongside that, access and delivery of effective essential services. As both you and Ambrose have pointed out, there is great disparity across the continent between countries, but also disparities within countries. So we do need that data. We need that data to be timely, and that's a challenge in itself. So thank you so much for bringing a real case for discussion. I would like to remember our audience. We have 165 participants. Thank you so much for joining. The chat icon is available for you to post your questions, your comments. Please do so. And I would also like to let you know that we will be sending the recording of today's webinar during next week. So be sure to watch your email boxes for that. So now I would like to turn to the question and answer portion of a webinar. We have a full 30 minutes to do that. Thank you so much to our presenters, for keeping the allotted time. And I would like to present two members of a panel who will join the presenters in this discussion. Dr. Pierre Barker, who oversees the global programming at the Institute for Healthcare Improvement, speaking to us from Boston, and Dr. Ali Oswenar, an infectious disease and health system expert with APT Associates, speaking to us from Maputo, Mozambique. So I would start with Pierre while we receive more comments from the audience. Pierre, we have heard how the COVID epidemic is affecting the delivery and uptake of non-COVID services. Through your organization, IHI, you've been involved in supporting government's responses to try to maintain non-COVID services as the epidemic unfolds. Can you describe this experience and the approach you're using?
Thanks very much, Midori, and hello to all of the people who've joined. And I think we've heard already, I think from Richard and Ambrose, about the potential impact on the resilience of systems and also on the non-COVID services. And I think there's some fairly scary data or some scary modeling, at least, out there about the potential impact of COVID on the non-COVID services like TB and malaria, and particularly maternal child health. And we are in the fortunate position of working in the field for some of those services, and I wanted to just briefly relate our experiences in South Africa around TB and maternal child health. So we saw the data that Richard presented earlier about the national labs reporting a really scary drop in the reported number of tests and new cases being described as positive for TB, about a 30% drop. And so we have a closer look at what was going on at the clinics that we support in about 5 districts across South Africa, and try to get to the bottom of what might be going on. And I think our findings correlated somewhat with Richard's in the sense that we found that people were generally coming to clinic. There was only about a 10 to 15% drop off in the head count year on year, certainly for the last couple of months. But what we did confirm, in fact, was that there were significant decreases in the cascade for TB care, and we predicted there would be similar decreases if we looked for them in some of the other chronic services as well. So screening rates were down, testing rates were down, and the starts of new patients on TB were down. So this is a really major concern in terms of program performance. And we also had a look at data quality, which we always worry about since we watch the data very closely, and this is how we know that we're making an impact when we're trying improvement. And we found that there was a significant decrease in the completion of data. So the whole data system had been disrupted as well. We started to look a little bit more closely at why this might be. Certainly, I think far and away the clearest reason for this disruption was that the attention of the staff had really been diverted. Many of the staff whose job it is to take care of routine patients had been redeployed, in fact, to COVID care. And it's very important to think of this action in the light of the modeling predictions that we're getting now about what the impact of a decrease in the regular services might be on mortality for mothers and newborns, people with potentially with malaria, TB, and HIV, which would be far, far greater than the predicted impact of COVID. So it's a real emergency to get on top of this issue. So yes, as far as TB is concerned, we took a sort of a health systems view, and we focused in on 2 areas. One was really trying to integrate COVID and TB services at the point of screening and testing. So every patient now is being screened as they come into the clinic for COVID, and we are testing out ways in which we could get effective combined screening for TB and for COVID, since there's a fair amount of overlap, in fact, in the questions that are being asked for those two. So that's one very practical way of trying to get benefit for both services and really focus on this idea of integration of services. The second really is to say, well, in a situation like this, only do the activities that you know are really high yield. So for TB, we know that there is a very high yield if we look at the combined HIV and TB population. So really, if you're going to spend effort trying to track patients, focus in on those areas that you know will give you very high yield. When we turned to maternal child health, we took a very similar view, and we asked ourselves, what are the main risks to the maternal child health service in the era of COVID? And we came up with 4 areas, which I think are fairly universal if we think about the services that are going to be compromised by COVID. First is the facility ready for COVID? Do they have the PPE? Are they trained? Have they adapted their protocols? Secondly, will they be ready to deliver non-COVID services? So can we think ahead about, particularly for maternal child health? We know from Richard's data that the maternal child health services are probably going to be disproportionately affected. Mothers don't want to bring their children in. But we now have data to show that for every one child or family that might get infected with COVID for coming to the clinic, modeling suggests that we will lose 120 odd children due to not being properly immunized or protected. So the risk is enormous, and we need to be able to communicate this kind of thing. Thirdly, will they be safe when they come to the clinic? Will the mothers be safe? Will the children be safe? And particularly as well, as Richard was saying, will the staff be safe? So we have to take care of that and build systems for that. And finally, will they come? Will patients actually turn up? And there's an enormous role, I think, for getting messaging out in terms of the precautions that the clinics are taking and to make sure that patients are safe. And the real importance of coming when they need to come, and potentially of not coming, honestly, for the services that can be provided more remotely or through telehealth. I'll just finish by saying, when we look at our health systems response, we need to think of not only the issues around readiness and changing protocols, but also how we can support the services. So increasingly, we're learning a lot about remote learning, remote delivery of training programs, increasing use of virtual platforms, and I think there'll be a lot more that we can learn about that going forward.
Thank you, Pierre. That was really interesting. Yes, we are facing both demand and supply factors that need to be understood so that essential services continue. And changing technology, adapting the provision of those services under lockdowns or social distance conditions make it especially challenging. And there's where we can turn to new technology, digital technology, remote kind of services. But we are learning, on the learning curve for that. With that, let me turn to Ali and ask him specifically about the program, HIV program in Mozambique, and what effects of the COVID emergency has had on that program, and how the Ministry of Health is mitigating these effects. Also, how is your project contributing to this effort? Over to you, Ali.
Thank you, Madori, and hi to everyone. Mozambique is like the neighbor country of South Africa, and COVID started basically at the same time, and the first case was notified on the third week of March. Jointly with the Ministry of Health, ECO project run by APT Associates in 4 provinces in the country started like measures to ensure that the HIV patients will like continue on care as they are like kind of one of the risk groups for like COVID infection. The data that we are like analyzing in March show us a drop like in patients coming for their drug pickups, but not significant as like for February or January. But we have observed in April an increase in terms of defaulters, which have like motivate us like to start with the Ministry of Health kind of actions in order like to get like the treatment to the patients. So one of the things that we have implemented during the last weeks was the multi-month drug distribution in order that the patient can get like drugs for like 3 months, which would allow them not to come on a monthly basis to the health units. And we have like seen that this is one of like the things that have like lots of acceptance and success among the patients. And up like to the second week of May, more than 60% of the total of the patients that they are followed in the program have been like put on like the multi-month drug distribution. Combined like to the community drug distribution for the defaulters, this is another action that can like allow to reach out to the patient that they are not coming to the health facilities. Still, the risk of infection in the health units is like kind of high. The HIV program in Mozambique is well integrated on the primary health services, and we have like with the Ministry of Health organized the patient flow in order to minimize the risk of infection, and at the same time have been putting like appointments for the patients that they can come on different times, not to have all the health facilities crowded during like the first hours of the day. We've been observing as well a decrease in viral load analysis, especially during May, which can be like understood by the fact that most of the patients now are like coming to pick the drugs, but not like to take like other services as blood samples, among like others. So we are like trying to learn out from the data that we are gathering how we can ensure that those patients will have like their viral load controlled, and at the same time be sure that we can increase like the new patients, the new diagnosed patient on HIV to put them on treatment. We are working in collaboration with the Ministry of Health on this, and we are like seeing that the data from May in terms of active patients is better than the one that was in April. And this is because of like information and education messages that they were like sent like to the patients, and as well because of the efforts of the health workers to be sure like to attend and to prioritize HIV patients in terms of consultations and other services. For like the health facility workers, they all have like their like individual protection material, and that they're receiving kind of sessions of information on the COVID and try like to protect them, as like Dr. Richard was saying, because they're like the most valuable actors for the moment. I will just like finish on saying that the resilience of like primary healthcare in Mozambique and other countries facing this kind of stress is like the only way to get through, ensuring that we're going to continue the basic services for the most among the population. Thank you.
Thank you, Ali. And now I'd like to turn to the questions we've been receiving from the audience. Very interesting questions. Not surprisingly, there are some questions directed to the effects of the lockdown on childhood vaccination, and if there have been reports of outbreaks of vaccine-preventable diseases like measles and others from different parts of Africa. And I would like to direct that question to Ambrose.
Thank you very much, Midori. And I saw that question in the chat. Yes, and first of all, if I give a background, before even COVID, measles was the cause of outbreaks, and that's really a reflection of challenges with routine immunization for measles. So we've been seeing a decline. We have at least a persistent decline in routine immunization for measles. And so we had major outbreaks in the recent past in the DRC, in the Madagascar. We are really putting this on the radar, even in Chad. So we are tracking, telling countries to track outbreaks of measles as a proxy for drops in the likelihood of childhood immunization. But as of now, I think maybe we are still early into it, and we still have an ongoing outbreak in the DRC there. Well, that is the one that I can document. But I think it is likely that we are going to have increases of outbreaks, even other outbreaks. We already have another outbreak of Ebola in the DRC, which was reported just this week. Over to you.
Thank you so much. There's an interesting question about modeling. What modeling exercises have been carried out in Africa? Maybe, Richard, you mentioned that. Maybe you could give us a little bit more of information.
Yeah, I mean, I think there's been a lot of modelling, and if I'm completely honest, I haven't caught up with all of it because I'm quite substantially behind in my reading at the moment, as I'm sure we all are. It's impossible to keep up. I think there's certainly been a lot of modelling around TB and around HIV. I think certainly one of the things we discuss here is really trying to flip it round a bit and think about some of these diseases and the opportunities that we have to take what we're doing for COVID, what we're learning from COVID, and use it as a positive for our response to HIV and TB. And certainly that comes back a little bit to certain things we've discussed, like the infection prevention and control. I think the urgency that we've had to deal with that here has flagged up that we still do very poorly for TB infection control. So for respiratory disease infection prevention and control in general, there are a number of weaknesses in our system. And I think that we have to think about the opportunities at the same time as obviously mitigating the negative impacts, the negative effects. So that's something we're certainly spending quite a bit of time on now, is thinking about what are the positive opportunities in terms of the TB control and HIV prevention and treatment. So I'm not sure that's directly answering the question, but the basic answer is that there's an awful lot of modeling going on. But I think, as I said at the beginning, we need to start seeing the real data and understanding the reality in different settings.
Yes, thank you so much. There's been also an epidemic, right? So much information to catch up to. It's almost overwhelming. So, Pierre, I have a specific question for you. How can we apply quality improvement approaches at the national, subnational, facility levels in our quest to maintain essential health services? Any examples you would like to share with us?
Sure, I saw that question from Dr. Said at the WHO, and I do think that there are some big opportunities, as Richard was saying. I think for us, the way we're looking at it, I think the biggest opportunity is, first off, systems thinking. Like there is a big, at the moment, emphasis on getting ready for COVID, getting systems prepared appropriately, and training for something that we've never seen before. On the other hand, I think this is a great opportunity for systems thinking and integration of services. And so the example I gave you about the combining the TB screening with the COVID screening is really a great example of what could be done and what should be done into the future in terms of systems integration and really simplifying what is quite a chaotic situation that we find ourselves in at the moment. The second piece of this is really around rapid learning. I think when we're confronted with something that we've never dealt with before, we can't reflect on our, textbook training, our medical and nursing school training. We can't reflect on established protocols. This is a condition that most clinicians will have seen only similar examples to, but never having dealt with anything of this scale, of this severity in a population before. And so we need to use the fundamental quality improvement method of rapid learning, understanding that we don't have all the answers and that we need to set up good learning systems to be able to learn from each other, network with each other, have very clear, simple ideas for responding to the situation that we are prepared to quickly test, report out, and very importantly, track with data. If we don't have data, we're just shooting in the dark. And so I think these are the fundamental principles of QI, systems thinking, rapid learning, and tracking with data that I think stand us in very good stead when we're dealing with a complex moving target like COVID, and which has the potential to disrupt the whole system. And I think it does also speak to Ambrose's notions of resilience as well. I think that if we have a clear, systematic approach that is very much driven by learning and by data, I think we can arm ourselves well to deal with this.
Thank you. Thank you so much. I have a great question here that I would like really to pose to all of our members of the panel. I'll start with Ali. And it says, rightly so, that much of the discussion has been system facility-based. Can we speak a little bit about outreach and community-based services in the community and how that figures into the prioritization when we're configuring essential health services during COVID? This is really a great question, and it relates to this rethinking of health systems as well. So what can we say about outreach and community-based services? Ali, over to you, and if somebody wants to join on this discussion, please do, the rest of the panelists.
Thank you, Madhuri, and thank you for the question. It is really great, and the equation that we are seeing now regarding to this new pandemic that we don't have all the answers is combination of a primary health care and community health work that all together can answer at certain points to the needs in some health systems. Mozambique is among them, that they are still with a lot of limitations. So in our experience as a HIV program, we are always going to the communities with our counselors and community health workers to follow the falters and to pay home visits to them. But with the COVID now situation, there is kind of move to drug distribution at the community level, which was not allowed by the Ministry of Health before the COVID, but now the Ministry of Health is stepping front and allowing at certain point the defaulters, the patients that they are not coming for their consultations to pick their drugs, that they can have this service at the community level. So this is like one of the things that we are like now like seeing moving with the COVID. But like talking about like the community health in general, I think this is like really a key moment that so many countries can have like really a strong commitment to the community health workers, to the community programs, because part of the sensitization, diagnosis, and reference of the patient start within the community. Most of the African countries have not like really this statue of the community health worker as a professional or like not paid. It is not the case in Mozambique, but in other countries like Madagascar and so it is the case. It's still voluntary work, and we can really think that increasing like the portfolio of activities that community health work can do, especially in this emergency situation, can help in the resilience of the health system. From another comment from the side, now like with the demand on the community health workers during like the COVID situation, the same trend that was observed at the health unit could be observed at the community health workers in terms of diagnosing malaria, treating like pneumonia, and so. So this is like really the moment where like we need like to follow closely how the community health work is going and try like to advocate more to make it more official in the ministries of health of many African countries. Thank you.
Thank you. I was wondering if
Midori,
the panel would like to comment on outreach and community-based services and the relationship with health system resilience.
Midori, I wanted to comment on I think that's a very valid question on community service. I think we can't look at continuity of essential services without looking at it from the community level. And really this is, as WHO, we've been encouraging countries to look at the community level what is already existing that they can build on in terms of governance structures at the community level where we can leverage interventions at the community. In terms of workforce, again, trying to map community health workers and see where they are not in case there are going to be redeployments or resurgences, upsurges of capacity upsurges in different areas which might not be having the kind of community network of workers, but also to look at the incentive schemes for community workers working extended time in case they are doing that. And also then finally the infrastructure at the community, and then opportunities to use community health workers to deliver some of the medicines. We're seeing some examples in some countries with delivering some of the chronic medicines for those people. And finally, I think the information at community level is making sure that whatever event is happening, a sort of event-based surveillance is reported by those community workers. And most critically, the relevant actors at community level who are the community themselves to ensure that they are really engaged. So that's really a very valid point. We can't look at continuity of essential services without looking at the community level.
Thank you so much. And I'm afraid that we are running out of time. Thank you to our panel, our presenters. I think this has been a great discussion. I would like to stress what was said. Pierre has said about rapid learning. How can we really develop skills to learn from our current experience and do it in an efficient, timely way? I've learned so much from the panelists. Thank you for sharing. We do have a lot of great questions that we haven't been able to come to. So sorry about that. We will be sending the recording of today's webinar next week. As I said a while ago, please watch your email boxes for that. And with that, thank you so much to all of you who have participated with your questions. Stay safe and have a great rest of your day. Bye-bye.